More than 20 years ago, it was discovered that CML, chronic myelogenous leukemia, had a single genetic marker or target, BCR-ABL. But it's only been recently that we've discovered that CLL also has common molecular targets that can be focused on to treat CLL. For years, we used simply chemotherapy that was palliative, that didn't improve overall survival or progression-free survival. With the advent of anti-CD20 therapies like Gazyva and Rituxan, we began to improve overall survival. But in recent years, with our understanding of the molecular pathways, especially the BCR, B-cell receptor pathways, we've understood the importance of Bruton's tyrosine kinase, which led to the development of ibrutinib and subsequently development of other molecular targets that have improved overall survival as well as progression-free survival in CLL. So the real challenge for us in managed care is to help ensure that we provide access to the most effective therapies for these conditions, moving away from chemotherapy-based regimens to include anti-CD20 therapies in combination with molecularly targeted therapies, and sometimes molecularly targeted therapies as a standalone. We use in our health plan, and most health plans, use the NCCN guidelines to help define what is considered the standard of care, and our objective is to ensure that we provide access to those standards of care. Ironically, historically we've looked at a number of different categorizations, those who are frail and have multiple comorbidities, those who are over age 65 with comorbidities, and those under age 65 and are otherwise healthy. The advent of new molecularly targeted therapies has really diminished the need to understand those different categorizations and has focused more on high-risk factors such as 17p deletions, 11q deletions, 13q deletions, complex morphology or complex karyotypes that are all helping to understand which therapies should be used in which patients. As in most cancers, the primary unmet need is for long-term survival, and secondarily, long-term survival with either reduced toxicities or the ability to go treatment-free. Even with the advent of ibrutinib or Imbruvica targeting the Bruton's tyrosine kinase, there are still very few complete responses. In subsequent studies looking at venetoclax, there are higher rates of complete responses. But nevertheless, there aren't 100% complete responses in any of these targeted therapies. So it's going to be very interesting to look at the combinations of multiple targeted therapies to see if we can induce complete responses with minimal residual disease and potentially the ability to go without treatment for a long period of time.